Yes. Doctors, we are live on the YouTube. Doctor, we can start the talk show.
Okay, shall we start?
Yes, ma'am.
Okay. Hi, everyone. I'm Urmi Sheth. I'm practicing hematologist at Dinanath Mangeshkar Hospital and KEM Hospital, Pune. I'm glad all of us took out time and have joined this meeting on the Women's Day. Happy Women's Day, everyone.
Happy Women's Day.
Okay, so let's start. I'm going to be asking a few questions based on general hematology to our participants. We have Dr. Shruti Toshniwal, Dr. Shweta Lunkad, Dr. Fahima Hassan, and Dr. Radhika. Is everyone present?
Yes.
Okay, come, let's start then. So feel free to answer. It's directed to all of you. Anybody can, I'm not going to call out names. Anybody can participate. Um, let's begin with hemoglobin. I think we'll answer a few questions about hemoglobin and move on to platelets and then move on to normal WBCs and then more difficult questions regarding blood cancer. So, what is normal hemoglobin for a female and what is anemia? Fahima, would you like to take the question?
See, since it's for the lay people, I'd like to start explaining what exactly is anemia. When
Sure.
your hemoglobin levels fall below a certain acceptable norm, which we usually take for an average Indian woman as a hemoglobin of 12 grams, we call it as an anemia. So this is what even the WHO says. The very striking thing about Indian women is that in the world, if we see 1 in 3 women have anemia by this definition, but shockingly, in India, 57% of women suffer from anemia. So it's an even more issue in India than a global one. So yes.
Right. So, can you highlight what are the, since this is for the lay people, can you highlight what would be contributing to such a high percentage in the Indian subcontinent for anemia?
Yeah, the most common cause of anemia in Indian women is nutritional. Nutritional in the sense that it's because of inadequate or substandard food you take. It causes iron deficiency, that is decreased iron intake, which causes anemia. So iron deficiency seems to be the most common cause of anemia in Indian women, mostly due to poor nutritional intake. So, and we also have this veganism and vegetarianism in Indian country. That is one of the most common thing, and neglect because of the sexual bias and, not looking after themselves. That is one of the most common cause of anemia.
Right. Some other contributing factors that come to my mind are worm infestations, probably menorrhagia, which is neglected,
Definitely,
not
definitely. They
being,
just come to
looked
hospital.
after. And there's
Yeah,
such a taboo. Women don't come out and open and talk about it either.
exactly.
Right. So, how can one maintain a normal hemoglobin? Through diet? What specific diet?
So,
Any
the most
precautions to
important
be
way, of
taken?
course, is through a healthy lifestyle, eating adequately, eating your greens if you're a vegetarian, including some good red meat if you're a non-vegetarian and vegetarian kind of a diet, and having a good healthy lifestyle, addressing if you're having, like you said, menorrhagia or any other symptoms, where you have excessive bleeding. So these are the main reasons. And of course, in poor socioeconomic classes, it's also important that we look into parasitic manifestations, which can cause significant GI loss. So since we are talking about, the peak reproductive age, the main cause is actually nutritional and PV bleeds, which we'll have to address, and also worm infestations. Because the causes of anemia varies depending on the age group. So, yeah, if you are an older female, post-menopausal, you have stopped having your menses, it is definitely a red flag. So please investigate for any level of anemia if you are especially postmenopausal, or if you are having your proper diet and you are still having some good degree of anemia going. So yeah, so these are the main things to be, and the red flags to be addressed.
Sure. And since we've already touched upon the reproductive age group, not having pregnancies back to back, keeping a minimum gap of 2 years, as they suggest, will also help in avoiding iron deficiency amongst these group of women. Can I move to Shruti?
Yeah, hi.
Hi. So, will you help us by telling what are the different types of anemia? We spoke about nutritional, but are there other types of anemia that one needs to be aware of?
Yes,
And
yes.
what are the signs and symptoms? And when does one
Actually,
contact?
as this we are dealing with lay people, everybody. So I'll explain in very simple terms. So like what we discussed earlier, nutritional. Because whatever we produce, like whatever our body produces, hemoglobin, RBCs, WBCs, platelet, is produced in the bone marrow. The bone marrow is like a factory of production in our blood production in our body. So, like we spoke about nutritional, which provides raw material to the bone marrow. So, if the raw materials are less, then the machinery will not work. The machinery is defective, like you have defects in the RBCs. Like RBC defects, you can have congenital effects, your genetic problems, where your RBCs are not formed properly, where your hemoglobin structures are not formed. We have various congenital anemias where your machinery is defective. If your like thalassemia is very important. Thalassemia, sickle cell anemia, a very important cause of anemia which has to be looked after. So stressing in thalassemia, I would like to stress here that we need to find out more and more thalassemia minor or thalassemia trait in the society, so as to we can prevent thalassemia major in the next generation. So identifying thalassemia trait is as important as treating nutritional anemia in the reproductive age group, as we spoke about. So by doing a simple test of HB electrophoresis, you can detect that you are thalassemia minor, and you can do your screening. Because from where I come from the state of Maharashtra. So the carrier frequency of thalassemia minor is around 4%. So we test randomly 100 people, 4 will be having thalassemia minor. And sickle cell in some belts, it goes up to 20%. So it's screening is very important modality here. Apart from that when your raw materials are there, your machinery is intact, you have some factors where you can have anemia due to you can say destruction of the RBCs. Like you have various causes, like you have your autoimmune hemolytic anemia in the females in the reproductive age group, or in the young adolescents. We have to keep these factors in our mind. And also you have a lot of bleeding tendencies which are going on, like menorrhagia, they have bleeding through some other sites. So the bleeding patients can have anemia. Also systemic disorders like liver dysfunction, kidney dysfunction, various other GI problems, like you have your malabsorption syndromes, where you have where you can get anemia. So all these disorders, so anybody who is anemic should go to a proper doctor, get himself screened. What is the cause of anemia? Once we know the cause, then we can direct you for the appropriate treatment.
Absolutely, Shruti. Very logically explained for the layman from the point of factory, raw materials, production, and then destruction. Can you also tell us what are the symptoms of anemia, and how does one know that one has low hemoglobin, and when does one contact the doctor, and who is the right person? Of course, we are all hematologists. We know they have to come to us, but should they be going to a family physician first, straight to a hematologist, and what are the signs and symptoms to look out for?
Yeah, the most common signs and symptoms that you should all look out for is like we should this fatigue out of proportion fatigue. You have breathlessness, you have pale skin, you have dry hair, you have brittle nails, you have lot of hair fall. If you are having tingling, you are having tingling in your extremities, then you are having syncopes, you are feeling dizzy while doing your routine activities. Apart from that, some specific symptoms which you want to look out is, are you having some craving for eyes, or you are having restless legs, that are very specific, like craving for abnormal material like the paints and everything. So that indicates that you are having anemia. So also, if you are having all these symptoms, you should simply go and consult first your family physician, because that is approachable. And once you get your CBC done, he will refer to us, like to the hematologist, or you can directly come to us. But everybody, like every city, you don't have hematologist. So basically, you can just consult your family physician, and then he will refer to you a proper person.
Sure, sounds great. Radhika, hi. Can you tell our viewers what are the tests? Are those blood tests? Are those any other tests that we need to do to find out one has anemia? And is the treatment simple? And elaborate a little bit more on the management.
Yeah, Dr. Shruti has very clearly elaborated on the causes of anemia. So whenever there is a suspicion, a clinical suspicion of anemia, like patient have symptoms of anemia like shortness of breath, easy fatigability, increasing paleness. The first thing, the test what we recommend initially at the clinical first contact is a complete hemogram, a blood picture, wherein we read the red blood cells, wherein we look at the red blood cells, the morphology of the red blood cells, what is the count of the red blood cells, are they normal in morphology or abnormal morphology? So this is called as a complete hemogram or a complete blood picture. This is the first test we want to do to check whether the patient has anemia, and if the patient has anemia, what is the level of anemia? Mild, moderate, or severe. Somebody whose hemoglobin is less than, is around 11, more than 11, we call it as mild anemia. More than 7, it is moderate anemia, and less than 7 is severe anemia. Now that I got a hemogram done, patient's hemoglobin is low, and I have documented the patient has anemia. Now the next thing is I would like to know why the patient has anemia. So there are certain blood tests which will direct me towards the cause of anemia. Like if I'm suspecting nutritional anemia, I would get serum iron studies done, vitamin B12 levels, folic acid levels. If I'm suspecting an anemia due to some chronic disease, my liver function test, kidney function test will be done. If I'm suspecting an anemia because of breakage of blood, like the hemolytic anemia, there are some other tests like the liver function test, LDH, haptoglobin, Coombs test, direct Coombs test, indirect Coombs test. If I'm suspecting an anemia because of an underlying malignancy in an elderly man, then I'll have some other set of tests. So basically, a complete hemogram to know whether there is an anemia and what is the degree of anemia, and then some specific tests like whatever I have, blood test, ultrasound abdomen. In some cases, we may even have to go for a bone marrow examination to look for certain causes of anemia, especially in elderly people. So these are some of the baseline tests where the patient has. And the first and foremost is always a CBC, a complete blood picture, which will give us kind of 50% of the answer is shown by a complete hemogram seen by a good pathologist on the lab background.
Correct. Oh, great. So I think the only thing I would like to add is I'm sure all of us have counseled thalassemic patients and we've all told them not to match Kundli, match the HPLCs instead, which should be the norm in especially the thalassemia and sickle belt region. Well, let's move on to the next blood hemogram component. Let's start discussing a little bit about platelets. Anyone can take this question. Let's start with what is a normal physiological role of platelets in the body. Fahima, will you tell us a little bit about what platelets do in the body?
Yeah. Platelets are basically, gums or adhesive substances which prevents you from further bleeding. So the normal platelet count, as per the definition, is 1.5 to 4 lakhs. So wherever there is any evidence of an endothelial breach or your blood vessels is damaged, these platelets acts like gum and goes and sticks onto it and prevents from bleeding. Say, for example, you get a small cut. We see that the blood starts leaking and it stops on its own. So the first thing your body does to prevent bleeding is to send your platelets to the side and activate it so that there is no further bleeding. So these are basically platelets for you, God-given gums to prevent bleeding.
Absolutely. Sticky things, little white sticky things running around in the blood. True. Shruti, what are the conditions in which you have low platelets? Can you just tell? the viewers a little bit.
Patients can have low platelets in various conditions. Like commonly, we see low platelets in megaloblastic anemia or nutritional megaloblastic anemia, where patients have deficiency in folic acid and B12. Apart from them, they can have low platelets in viral infections. A lot of viral infections can give rise to low platelets, like your dengue, your chikungunya, a lot of viral infections. Also, apart from then, that we have a condition called as immune thrombocytopenia, where your immune system start disrupting your platelet. So, this is a very common cause of thrombocytopenia. What we see. Also, thrombocytopenia can be seen in acute leukemias, blood malignancies, lymphomas. They can see in secondary other malignancies. They can seen in diseases where you have a weak spleen, splenomegaly is there, which can cause thrombocytopenia. Apart from that, you can see your low platelets in your liver diseases, your kidney diseases, and serious infections. You can have low platelets. So these are the most common causes of low platelets what we see around.
And how does one know one has low platelets? What are the symptoms?
If somebody is having low platelets, they will have bleeding manifestation. They can have petechiae, like the small red pinpoint spots on the skin. They can have ecchymosis, which is the blue-green patches will have on the skin. They will have bleeding from other sides, like gum bleeding. While brushing their teeth, they will have bleeding from the gums, or they can have black stools, which are the sinister bleeding. Like if these are the danger signs where you have your blurring of vision, your severe headache, you have your melena, which is a black tarry stools, then you should immediately consult your hematologist or healthcare professional and get yourself checked for low platelets.
Right. And is the treatment for low platelets the same for all conditions, or do we have different treatments available for low
Because
platelets?
it's very important to know what is causing your low platelets, because from simple megaloblastic, like just supplementation of B12, to serious problems like blood malignancies, we have a spectrum of diseases which causes thrombocytopenia. So we need to know exactly what causes thrombocytopenia, because treatment varies from disease to disease. You just cannot rely कि platelet कम है तो चलो kiwi खा लो और papaya खा लो
Papaya
and
leaves
all those
ले
things.
लो.
And
That's
everything is not same in everything, and there's a lot of studies which indicate that these things don't work. So people
correct.
should be aware that not spending, because few of my patients, they said okay, this one condition like pseudo thrombocytopenia, where you need a hematologist to tell that you don't have thrombocytopenia. So we do a peripheral smear and we say that okay, your platelets look normal, only the machine is telling that low platelets are there. So
Correct.
this one of my patient told, I ate 10,000 rupees of kiwis just because many people told me that I have thrombocytopenia. So then just consult your doctor and check your CBC before you take any decision on your own.
Right. So I think the message we are throwing out here is right diagnosis at the right time will lead to the right treatment. Don't self-treat and stop buying papayas and kiwis just when you think your platelets are low. Please contact your doctor. Right. Radhika, when do platelets go up? Is there a condition in which platelets are abnormally high? And do we need to be worried about that?
In hematology is all about the three blood cells, the red cells, white blood cells, and the platelets. A low count is dangerous. Equally, a high count is also dangerous here. So a low platelet count is dangerous. At the same time, a high platelet count is also indicating us towards some kind of danger. So what are the conditions where we are likely to see increased platelet count? There are certain conditions, like first and foremost thing, where a patient has an iron deficiency anemia, nutrition anemia, or an iron deficiency anemia. Platelets can have reactionary high platelet count. You correct the iron deficiency, you give the iron injection, automatically the platelets revert back to normal. There are other certain conditions wherein you can have reactive, what's called as reactive thrombocytosis. That is very normal, but in reaction to certain happenings in the body, the platelets increase, like in infections, or whenever there's some inflammation going on in the body. Whenever there's a tissue injury, patient has a road traffic accident, there is some tissue, leg or bone got churned or destroyed. Reactionary, the platelets increase. They go to the site of injury, and there is a role for the platelets to play there. Something like wherever there's a fight with India-Pakistan border, all the armies from around the country, they go and pool near the, so something like that. The third thing is platelets can also increase in certain abnormal hematological conditions called as myeloproliferative neoplasm. There are certain conditions in hematology where the control of the growth of platelets go out of the way. They,
Sure.
the body produces them in an abnormally high pattern, something equivalent to a cancer or a blood cancer, something like that. This is called as myeloproliferative neoplasm or essential thrombocythemia, or there are some other conditions like that. So the main are viral infections anemia and the reaction in thrombocytosis, if you get to see an injury or inflammation or infection. And the third is myeloproliferative neoplasms, like what I said. Also, in certain blood cancers like chronic myeloid leukemia, which is also actually a type of MCM, where we see increased platelets. So, I think these are the differences in that.
Yeah, I think you've covered almost everything. Let's talk a little bit about blood cancers. When do we suspect it in a patient, and how does the patient know patient has it? When does the patient contact the doctor? Or let's start with what is blood cancer? What are the different types of blood cancer? Shruti, can you
Yeah.
tell the audience?
So, like blood cancer, when we talk about blood cancer, we talk about three important entities like your leukemias, your lymphomas, and your myeloma. So, we have three major groups of cancer. So, depending on the symptoms, the type of presentation, again, we classify them as acute and chronic leukemias. So, then we have your acute leukemia, where patient is very sick. He develops symptoms rapidly. He has bleeding tendencies, and he comes to you like pyrexia, like fever. He has basically fever, bony pains, fatigue, bleeding tendencies, and anemia, which has developed over a very short duration of time. So these things fit in acute leukemia. We have your chronic leukemia, where incidentally patient has gone to a ophthalmologist for some cataract surgery, and incidentally he had found that okay, WBC are high, but he doesn't have any symptoms. So there comes your chronic leukemias. And apart from that, lymphomas, where you have your swellings in the neck, groin, armpits, you have fatigue, you have weight loss, which develop in a subacute way over three to or few weeks, few
Weeks to
months,
months.
like that. And then you have a completely different type of a malignancy which affects your bones, kidneys, and your blood, which is multiple myeloma. So basically, we deal with all these problems under the heading of blood cancer.
Oh, sounds great. Fahima, can you tell us just briefly overview about the treatment for leukemias?
So we are in an age of precision medicine. Like we have something or the other to give every kind of cancers right now. So we should be blessed to be in a place like this. So as Dr. Shruti was telling, majorly we can divide leukemias as acute and chronic. So chronic leukemias, mainly we are dealing with something called chronic myeloid leukemias and chronic lymphocytic leukemias. So myeloid leukemia is a poster boy of cancer, like where we just have to give a single tablet every day, like how a patient with diabetes or blood pressure is taking a single tablet every day to keep their disease in check. That's exactly how we treat this chronic myeloid leukemia. CLL, on the other hand, that too, like sometimes you might have to treat and sometimes you might not have to treat, depending on the patient's stage of the disease. So the therapy is also dependent on that. If the patient is early stage, we don't treat, we just wait and watch, because basically both chronic myeloid leukemias affect elderly or middle aged and above. So we avoid treating until and unless the patient has some symptoms which needs treatment, which might vary from just like a tablet every day to even chemotherapy, which we might give, every monthly for up to 6 months, depending on the type. So we come into the most dangerous kind of leukemia, that is the acute leukemia. So we have two types of acute leukemias, acute myeloid leukemia and acute lymphoblastic leukemia. They are life-threatening diseases and they do need chemotherapy and they do need expert hematological care and a proper setup to treat. So if you have these diagnoses, it's not very easy to elaborate on the therapy in this forum, but yes, you have to rush to a hematologist, start your therapy at the earliest. But the good thing is that up to 90% of patients with ALL can attain cure At least in Indian data, we have up to 70 to 80% with cure. And of course, acute myeloid leukemias with and without transplant. With transplant is extremely good. We can transplant, we can definitely give an option of cure for these patients.
Great. So message we are giving here is look out for those red flags, contact a doctor immediately. And this is a specialized treatment, life-threatening condition, requires a tertiary care setup. Right time, right treatment, right diagnosis can save lives. Radhika, can you tell us about age distribution amongst these three types of blood cancers? Whether do we see it in pediatric, younger girls, older women, reproductive age group? Is there a separate distribution? Is it seen across all ages, or do we have some coming later in the adult life, some coming earlier? Any distribution do we specifically know of?
Cancer, there are certain blood cancers which have higher propensity in certain age groups, like chronic leukemia, chronic myeloid leukemia can be seen in young adults, but predominantly it is seen in middle age group. Chronic lymphocytic leukemia, CLL, is a disease of predominantly aged people, more than 50, more than 60, 70, 85. Coming to the acute leukemia, it's like ALL, acute lymphoblastic leukemia. When this leukemia get an academic immediately, acute lymphoblastic leukemia do occur commonly in childhood and young adults, but can occur in any age group. Acute myeloid leukemia predominantly occurs in middle age and elderly, but still it can occur in any age group. Multiple myeloma. Myeloma is specifically a disease of elderly people who will get to that. Compared to the West, the Indian in India, like relatively younger people are fortunate. The disease of elderly. There are certain cancers which have a potential at older age. There are certain cancers which have potential at the older age, but nothing like it is restricted to the age group because anything can happen in the age group. Except for this CLL and multiple myeloma, which you don't get to see that is the case. So, these are different cancers which have a potential for different age groups.
Right. Okay, thank you, ladies. I think we had a wonderful conversation regarding the basics of all the blood components. I thank you for taking your time out, and I will now hand over to Dr. Neema Bhatt. She'll take on for the remaining of the half an hour this evening. Thanks.
Thanks.
Dr. Urmi. Hello all, I'm Dr. Neema. As Dr. Urmi mentioned, I'll be taking over the remaining half of the talk show. Hello to Dr. Radhika, Dr. Shruti, and Dr. Fahima, right? Dr. Radhika, if I may, your mic may be off a little bit. You were not very clearly audible to me. Is that the case for everyone? I feel like
the voice is cracking. Your voice is cracking a bit.
What you're saying is not clear. So I thought if you can fix it before we continue the conversation.
Yeah. I'll use my microphone.
Great. Yeah, that's better. Yes. So I'll start with the remaining questions. Am I audible to you, Dr. Radhika?
Yeah.
Okay. Yeah, so I think I'll ask Dr. Fahima the first question. So we have spoken about benign hematological and some, non-malignant and non-malignant, both hematological conditions. Other than hematological malignancies, which we just spoke about, leukemias, myelomas, and lymphomas, what are the other non-malignant disorders or blood disorders that the general public should know about?
One of the most common consults we have from other departments is thrombocytopenia. I think everyone must be aware of immune thrombocytopenia. That's one thing which really scares everyone. Platelet counts of less than 50,000, they come rushing to a hematologist, even though they don't have documented or peripheral smear. So I would like to talk about immune thrombocytopenia, where your immune system produces antibodies against your platelets. So since our immune system is very powerful, what this antibody does is they attach themselves to the platelets and they are just taken out of the system. So causing a tremendous fall in your platelets. So as I previously said, these platelets are adhesive gums, which kind of, prevents you from further bleeding. So what happens is the patient presents with bleeding, like even like brushing, they present with gum bleeding. So spontaneously, they might have these red patches or black patches all over the body. So we all know, we are all hematologists. We are talking about the three main components of blood, which is your WBCs, platelets, and your white blood cells. So every deficiency of every component has a different symptom. Like when your WBC is low, because they are one of the major component of your immune system, so you have recurrent infections. So when your hemoglobin is low, like how Dr. Shruti said, you present with fatigability because they are the ones which give oxygen to various parts of your body. So you get tired and you're not able to carry out your daily functions. So like that, when your platelets are low, you present with increased chances of bleeding, which doesn't usually cause bleeding, especially when your platelet counts, goes below 50,000. So yes, so ITP is one of the major concerns, and I think most of us must have heard it at some part of our life. So we have to be aware of this. So how you'll be aware of this is because of the bleeding manifestations which you're going to have, like petechiae or small red patches on your skin, or abnormal bleeding when you're brushing, or you might have excessive bleeding while you are having your menstruation. So yes, ITP is one of the major concerns. So there are various causes for ITPs. Majority of the time we don't know, but many of the time we do know, which is called secondary causes of ITP, which could be autoimmune diseases or any viral illness or numerous other conditions which can cause your body to make antibodies against your platelets. Yes. So this is ITP for you.
Great. So yes, ITP is one of the major hematological conditions, which is, even though if it is not blood cancer, it is something that we have to be very aware of. One more last thing I'd probably like to add is, although we should, yes, be very aware, there should be no reason to panic about it. ITP is a very treatable condition. It is not curable. That's how I put it to my patients. If it's picked up and diagnosed at the right time point, it's a very treatable condition. Patient just needs to be on medications and regular follow-ups, but there's no need for panic or anxiety. But yes, consulting the right specialist, which is a hematologist, is absolutely vital. My next question is directed at Dr. Shruti. What are the signs and symptoms of lymphoma, and when should we consult a hematologist when there is suspicion for lymphoma? This question has not been covered, am I right?
Yeah, it's not covered. We just spoke about different blood cancers in the last topic. So lymphoma, when person is to be suspected to have lymphoma, he will have abnormal swelling in the neck, in the groin, in the armpit. He will have fever, weight loss, loss of appetite, weight loss which is unintended weight loss. Over a period of time, weight loss is there. You have fatigue, you have night sweats, you have a lot of itching all over your body. You can have your swelling of your abdomen, swelling of your lower limbs. All these features we point towards some lymphoma, or excessive pains in your back pain, bone pains, everything. So these all signs will point to lymphoma. And if you have any of these symptoms, like you can have any combination of the symptoms, you need to consult your hematologist as early as possible.
Great. Thank you. Thank you, Dr. Shruti. Next question is for Dr. Radhika. We'll talk about what is aplastic anemia. What exactly do you mean by aplastic anemia, and what should the public know about, our viewers? What should they know about aplastic anemia?
Voice is not very clear.
Dr. Radhika, we can't hear you.
How about now? Is it okay? Is it good?
It's a little better. Can we make it a little louder if that's okay?
I have put it on the maximum.
Okay.
Microphone is not working.
I think when you had your microphone on, it was better.
That was not working.
Yeah.
Okay. Wait, just like this? Am I audible?
Yeah, better.
Great. I can increase.
Yeah.
What's my question?
The question is, what is aplastic anemia? Would you put it in a nutshell? What it is, what are the symptoms, and what it is that our viewers should know about?
Aplastic anemia is a term wherein the body's immune system recognizes our own body as foreign and tries to attack our body. Basically, the organ which is attacked in aplastic anemia is our bone marrow. Bone marrow, hematopoietic stem cell. Bone marrow is like the one inside the bone marrow bone, where the blood cells are formed. So our body has immune system because of whatever etiology. It may be because of some viral infection or some cancer or whatever, or most of the times it's idiopathic. There is no specific cause for it. So whatever etiology, our body's immune system goes out to the trap. It recognizes our body's bone marrow as foreign or abnormal or something, whatever. It's not its own. And the immune system attacks our own bone marrow. It attacks our hematopoietic stem cells, that is the parents of our blood cells, and then destroys the bone marrow. As a result, the blood stops forming in the body. So the blood is no more formed in the body. So all your blood counts, your red blood cells, your white blood cells, your platelets, everything gets low. So that is what is aplastic anemia. Basically, it's an immune-mediated destruction of the bone marrow hematopoietic stem cells. As a result, the blood is not formed in this. So all your blood counts will be low. So you'll have anemia, you'll have a low WBC count, you'll have low platelets. So you'll have all symptoms of anemia, low platelet count, and recurrent infections. This is what is aplastic anemia. It is a serious life-threatening condition because you need blood for your survival. So whenever you see these symptoms of anemia and thrombocytopenia, your recurrent infections, you go to a doctor or you get a test done at a peripheral hospital, you see that all your blood tests or blood counts are reduced. You want to immediately attend the doctor because it is a medical emergency. And it has to be attended at the earliest possible. The earlier you treat this condition, the better the response rate. The more you delay, the more likely that you will fall into the doctor's hand at a very terminal stage, wherein you may not be able. There are a good number of therapies and all available now. So it is still worrisome, but then still there are treatments which can revive the patient to an extent of around 80 to 90% in certain age group patients. So whenever there is suspicion of aplastic or diagnosis of aplastic, please attend the dermatologist at the earliest possible. We have treatment options. When compared to a decade back, we have better treatment options now available. Bone marrow transplant, ATG therapy, thrombopad, and whatnot. So that's what is my.
Thank you, Dr. Radhika. You made aplastic anemia sound very positive, so I think that's a good note. Being hematologists, we all get asked at one point or the other, how did I end up with blood cancer? Nobody in my family has it, but I have blood cancer. How was it possible, doctor? So Dr. Fahima, if you may take this question, are all hematological cancers related to genes? Is everything genetic? Is it originating only from the family? Is it only possible that if somebody else has it in the family, then I have to get it? What is your take on this? Dr. Fahima, you're on mute, I think.
Unfortunately, no, it doesn't stand true in blood cancers. It is not inherited or genetic most of the time. It's only in 5 to 6% of leukemias where we have an underlying genetic cause which is responsible for having started the leukemogenesis or the process of getting blood cancer in your body. Even though we don't know most of the causes of what caused the leukemia, we do know certain infections, viral infections predominantly, which can lead to leukemogenesis or the process of starting leukemia. We do implicate a lot of chemical exposure for leukemogenesis or blood cancer. So unlike many solid malignancies where we have a precursor condition, though we are trying on the verge of finding a precursor condition, majority of your leukemias, we still don't have. It just pops up, especially your acute leukemias. So most of the time we don't know the reason, and it's very less chances that it's genetically related. Though there are certain genetic conditions which definitely has a very high risk of leukemias, we do have that. But then you will definitely note in the family history that there would have been multiple patients or family relatives who have had such leukemias. But no, 95% of the time you are not genetically at risk for leukemias at least.
Thank you. Yeah, one more common question we get is, I have been diagnosed with leukemia. Is there something that I should get my children tested or my grandchildren tested? So that's another very common question we get as hematologists. And usually what we say is, if there is one particular targetable mutation or one thing that we know is consistently associated with leukemia in multiple family members, only then there's some point in testing. But most often that is not the case. Yeah.
Except in myeloma, where they do say there is some kind of a family risk, not in any of the other. And there are certain inherited bone marrow failure syndromes which can manifest way beyond, and there are certain even, myeloid mutations which can present late in the life, So there are some mutations called DDX41. Unlike in many of the family-related leukemias, they usually present in early part of the life, but now there are some novel mutations which even present the later part of the life. So these are the patients which we see. If there is this kind of a mutation, we do specifically ask them to screen the family, not otherwise. Definitely not.
Perfect. Great. Thank you. Dr. Shruti, can patients with hematological malignancies survive? And if they do, can they marry and have children? This is a little bit of a complicated question. It might take a little time to answer, but I think it's very important for our viewers if they have this question.
Like when we talk about hematological malignancies, like Dr. Fahima said, we talk about a spectrum of diseases. Like we talk from the chronic myeloid leukemia to the acute leukemia. So different type of therapies will affect your sperm and your ovum count, and then decide your further chances. And the complexity of your disease will decide how much the rates of. But in the age like we practice precision medicine, in a lot of advances we have, so a lot of cytoprotective targeted therapy we give, so we can spare your sperms and ovum. And if patient is having aggressive malignancy or going for transplant, we can counsel them, we can tell them that we can preserve your ovum, we can preserve your sperm before we give you chemotherapy, so that you don't land up in infertility in the long term. So this is the one point where you can take key. Yes, different type of treatment can affect your sperm and ovum count. You can preserve them and have a fruitful family life later on. Also, there are some disorders like chronic myeloid leukemia, where you can just treat with oral medicines, so you can have a near normal life expectancy. You can have a near normal your family life. So almost it's a near normal thing here. So we can discuss between these spectrums. How much your survival is there and how can you have a normal family life.
Yeah, if it is acute leukemias requiring a lot of more chemotherapy and a lot more significant cytotoxic chemotherapy, then the chances of reproduction or fertility comes down with it. But as you mentioned, most of the chronic leukemias and even some therapies for acute leukemias also, you can do fertility preservation and make sure that the fertility is preserved. Great, thank you. What are cytogenetics and what is immunophenotyping? I think this is very specific to hematology, but I'm sure our patients, even if somebody is diagnosed with leukemia, would probably hear that term sort of thrown out. We have to go through IPT or flow cytometry or cytogenetics. So Dr. Radhika, would you like to take that up? How would we explain this to lay people?
Yeah. The suspicion of leukemia is made on clinical presentation. The patient has certain symptoms of whatever, shortness of breath, some bleeding, spots, and all. Yes, and say doctor, that is suspicion. We do a hemogram, a blood test, a complete blood picture, wherein we see the leukemic blood cells, that is the cancer cells. Then we want to do a bone marrow and see how much is the cancer, how many cancer cells are there, 90%, 80%, what type of cancer is looking like in AML, ALL. So based on a bone marrow, we get an answer that we are dealing with a blood cancer, with this much is the bulk of the blood cancer. Probably it is this type of blood cancer, but it's not confirmed what cancer based on the morphology. So now I want to know, I know that I have a blood cancer, there is a blood cancer, but I would like to know what type of cancer it is. There are many types of cancer. There's a chronic myeloid leukemia, there's acute myeloid leukemia, acute lymphoblastic leukemia, there's a multiple myeloma. So what type I am dealing with? To know the type of the blood cancer, I need to get a specific test called as immunophenotyping. It is done by an apparatus called as flow cytometry, right? So I run a flow cytometry. Now I get an answer. I'm dealing with an acute myeloid leukemia, AML, or an ALL. Now I want to know, there is nothing like a staging in blood cancer because blood is all through the body. So you have a blood abnormal cancer cell here. You have the same cell in the brain too. It's not like a solid that it is confined to the liver. You call it a stage 1. It goes to the brain. You call it a stage 3. So in blood cancer, there's nothing like a staging. Now that I know what type of cancer I'm dealing with, I would like to know, is it a good cancer, an intermediate risk cancer, or a poor risk cancer? So for risk stratification, to know whether I'm dealing with a high risk cancer or a low risk cancer, I got to know the underlying genetic markers of the patient. So that's when I do a cytogenetic. So immunophenotyping is done to know the type of cancer, and cytogenetic evaluation is done to know the risk stratification of the cancer, the high risk, an intermediate risk, or a low risk factor, so that I get to know like what is the chances that the patient will survive, what is the chance my chemotherapy will suffice. So should I confine to a chemotherapy, or after chemotherapy, should I go for a bone marrow transplant? All this is decided based on this. And what type of chemo I have to give will depend upon what type of cancer I'm dealing with, AML, ALL, myeloma. So these are the two investigations. It's a very much mandatory wherever there is a blood cancer.
Great. So I think that segues into our next question, which I'll direct towards Dr. Fahima. What is bone marrow transplant? Just one question. What is bone marrow transplant? So you can answer it as elaborate or as short. You're on mute again, Dr. Fahima. Sorry.
So there are two types of bone marrow transplant. One is your autologous transplant, one is allogenic transplant. So I would like to compare bone marrow transplant to agriculture. So when are we doing bone marrow transplant? Most of the time, we do bone marrow transplants for malignant disorders, especially autologous transplants. So what we are trying to do is we give high dose chemotherapy, eradicate every single leukemia or any malignant cells which we are looking at, any hematological cancer, and we infuse stem cells. Stem cells are something from which all three cell lines can be created. As I previously said, there are three major components which make up our blood, that is your WBCs, your platelets, and your red blood cells. So they all come from the bone marrow. So for example, a patient has lymphoma, as we were talking about. So what we do is we give chemotherapy, make sure there is no more lymphoma in the body, and then we take stem cells from the patient's own blood. We give some injections for 3 to 4 days, and we mobilize the stem cells. These stem cells are in the bone marrow and they come to the periphery. We collect only the stem cells and keep. And then we give high dose chemotherapy to eradicate blood cancer cells wherever it is in the body and almost clean the entire bone marrow. So now it's like weeding, which you have done in your agricultural field. We've completely weeded out. Every single pest or whatever, what you call as weeds are removed. And then you sow your stem cells, which you have already collected and kept. So your stem cells go to the bone marrow niche and they start producing all three kinds of cells. So this is your autologous transplant. So in majority of your lymphomas, we go ahead, and myelomas, we do autologous transplant. In allogenic transplant, what we do is we take someone else's stem cells and we do the same thing, because we want to absolutely cure the disease. We want some action of the donor stem cells on the body. So that is when we do allogenic transplant. Like in aplastic anemia, we again do allogenic transplant, or we take the stem cells from the rest or the matched siblings or matched unrelated siblings. Match in the sense we have to see how much compatible your cells and your body, which we call as HLA typing, is that from the donors. So we prefer the ones with the maximum match, 10 by 10 match. So then we reinfuse. In aplastic anemia, what happens is your entire bone marrow dries up. Sook jata hai. That is the term I use. So we have no stem cells. So that is why we don't have, your hemoglobin is very low, your TLC is very low, your platelets is very low. So we give again chemotherapy. And since, like Dr. Radhika said, it's an immune mediated thing, so we remove all the T cells which was causing it, and then we infuse someone else's who is a matched sibling or an unrelated or a parent which is a haplodonor, which I cannot go in detail in this talk. Then we infuse the stem cells. These stem cells again go to the bone marrow and it produces all three kinds of cells. So this is bone marrow transplant in a nutshell, where after weeding, we fertilize the land and then we sow the seeds. The seeds are your stem cells and then they grow and then you have your fertile land back again. So that's BMT for you. Dr. Nima, you're on mute. Sorry.
Thank you. Thanks for correcting me. Yeah. I said that's very well explained in lay terms. I think most of our viewers should get what we mean by bone marrow transplant with your explanation. I like the comparison to agriculture and weeding it out. That's very similar to what I tell my patients. So yeah, great. Dr. Shruti, when would a doctor consider bone marrow transplant? So Dr. Fahima touched upon most of the malignant conditions where we do transplant. Is there any other indication apart from malignancy and aplastic anemia where we would also consider transplants? You're on mute, sorry.
A lot of congenital bone marrow disorders like thalassemia, your inherited bone marrow disorders like thalassemia, sickle cell, you have your bone marrow failure syndromes, Fanconi's anemia, where you where your bone marrow production machinery is faulty. So that time we do a transplant. Apart from that, we do transplants on a lot of like we said, malignancies, lymphoma, leukemia, myeloma, aplastic. These are the most common indications what we do. But apart from that, there are a few recent studies which have found that autoimmune disorders also benefit from autologous transplantation. A lot of autoimmune disorders, multiple sclerosis, there are a lot of studies going on. All these autoimmune disorders that they are getting benefited from autologous stem cell transplant, lymphoablative autologous stem cell transplant. So these are the new arena where autologous transplants have shown up to be very successful. So, like your routine, also there are various solid malignancies in children, like neuroblastomas, Wilms, where you have a role of autologous stem cell transplantation. So, apart from your routine hematological things, these are the things where bone marrow transplant can work. You're on mute.
Did we discuss sickle cell anemia and hemophilia earlier with Dr.
No, we
Urmi?
didn't discuss. Yeah.
So since we are speaking about benign hematological conditions and use for bone marrow transplants used in these benign hematological conditions, Dr. Radhika, would you like to take it up and explain what is sickle cell anemia?
So sickle cell anemia is inherited. It's a genetic disorder. It comes through the parental whatever, wherein the RBC gets deformed into a special shape called a sickle shape, crescent shape. These sickled or abnormally shaped RBCs, their lifespan becomes shortened. They don't survive for as long as the normal RBCs. So they break down early in the life. As a result, the patient will present with anemia or low hemoglobin. That is one of the presentation. The second presentation of sickle cell anemia is these deformed or sickled RBCs. They have little flexibility when they have compromised flexibility when compared to the normal RBCs. As a result, when they're traversing through the blood vessels to supply blood to an organ, they block the blood vessel. As a result, the blood supply to the organs get compromised. So the tissue where the blood supply gets compromised, the tissue becomes dead, or some organ dysfunction, organ failure can occur. So this is what is the pathophysiology of sickle cell RBCs. It's a genetic disorder. There's an abnormally shaped RBCs, which predominantly presents clinically to the patient with anemia and bone pains. More importantly, bone pains. The bone pains are because there's a compromised blood supply to the bone. The compromised blood supply because the blood vessels to the bones get clogged by this sickled RBCs. So that is what is sickle cell anemia.
Okay, thank you. We have a couple more questions, but I think we are nearing the end of the session. Since we are still in the process of sort of getting over this recent pandemic, Dr. Fahima, this last question, I think I'll probably direct it to you. Do we know of any malignancies that are secondary to COVID? And if yes, what are they?
As of now, we are not absolutely sure. That is the answer. It will take some time because viral-induced leukemogenesis is a chronic process. There are certain case reports. I myself had seen some of my BALLs relapsing. I don't know whether it's shortness of care because of the lockdown. So studies are still going on. As of now, we don't have definitive evidence for this. But yes, like any virus which can cause or induce leukemogenesis, we are not sure. We can definitely, we'll be knowing in the near future, I think.
Great. Yes, I agree with your answer completely. I mean, what we don't know today, we are probably going to discover 5 years later. Right. Yes, and we didn't have COVID until the last 3 years ago. So we'll probably start seeing the implications of it maybe in the decade to come. Any other takers, Dr. Shruti, would you, because I think this may have different takes, different people may have different takes on it. So Dr. Shruti, Dr. Radhika, if you would like to take it up as well.
Yeah, so people have a lot of misconceptions regarding COVID and its vaccination. So because we have given vaccination to approximately the entire population. So whatever the incidence of leukemia in the entire population is same as in COVID. And we are just too short to say that COVID vaccine is causing, because there's a lot of misconception among people that COVID vaccine is causing leukemia. So I want to clear that. COVID, it's very short term to say that COVID vaccine is causing leukemia. Vaccine has much higher benefits than the probable side effects. So please don't believe somebody saying if COVID vaccine is causing leukemia or COVID vaccine increases the chances of leukemia. The rate of leukemia is same as general population, but just everybody has taken COVID vaccine. So we like to think around it. So there are no confirmed reports, there are no confirmed data on that. Just like Dr. Fahima said, we need a 10-year data to say that whether it's causing cancer or not. So don't believe in the rumors that COVID vaccine is causing any major side effects apart from whatever the routine published in literature.
Excellent. I like your
I
take.
want to
It's a
say-
different take on COVID. So with the vaccine. Yes, Dr. Fahima.
Yeah.
Please.
COVID-associated thrombocytopenia. I have patients coming to me, hematological cancers and the risk of platelets falling after COVID vaccination. The risk of you getting COVID is more than getting COVID-associated thrombocytopenia. So please get yourself vaccinated. That should not hold you back, especially patients with myeloma. I suggest whichever phase of therapy you are, you can interrupt therapy for 2 weeks and go ahead with COVID vaccination. It is definitely there are cases of life-threatening thrombosis and thrombocytopenia secondary to COVID vaccination, but that risk is not as high as the risk of death with COVID, especially in our patient setup. So I promote and advise COVID vaccination in all these patients. And yeah, that I would like to say to everyone.
Great. Thank you. Dr.
I agree.
Radhika?
There is no data of a corona vaccine or a coronavirus causing any kind of hematological malignancy. They can increase the mortality and fatality of a cancer, but they do not cause cancer as far as the latest data. I mean, as
The
far as the
results
latest
have
data.
until now. Yes. Yeah. Great. I think with that, I've come to the end of the questions, and we've also reached our time. So if the Alchem team is online, I would like to mute my mic and let you take over.
Yeah, good evening, ma'am. Just allow me 2 minutes.
Yes, please go ahead.
So, ma'am, on the behalf of Alchem, I would like to thank you all for giving us such a valuable knowledge about hematological malignancy. It was really a great educational session, ma'am. Like a lot of insights we got from the session. So, thank you so much, Dr. Neema, Dr. Shruti, Dr. Fahima, and Dr. Radhika for sparing a valuable time and giving us such a wonderful insights. So, ma'am, it was really a wonderful session, and I really learned a lot from all great about the hematological malignancies. So, ma'am, on the behalf of Alchem, thank you so much, and wish you again a very, very happy Women's Day, ma'am. Thank you.
Thank you, all of you, and wish you all a
Happy
very
Women's Day, everyone. And
Thank
since for the viewers, I'm on Twitter and the handle Fahima Hassan. So any questions you guys have on anything related to hematology, you're free to tweet or text me or on Twitter.
Thank you, ma'am. Thank you, everyone. Good night.
Thank you, everybody, for a nice discussion.
Thank you.